And you can see here that these patients were also on a bunch of other therapies, which is always the bane of retrospective studies. We don't know what truly got them better. A lot of other drugs, we don't know whether they responded to these drugs or whether to the study drug. But the bottom line was they studied good endpoints, clinical endpoints, and showed an almost 40% reduction in the likelihood of severe outcomes. You can see here that the Kaplan-Meier curves are clearly split, whether you look at likelihood of progression to ventilator as well as death on the top two slides, or just death in the bottom two slides. And interestingly, subcutaneous tocilizumab did as well as intravenous tocilizumab. But there again, the infections pop up. You can see here that it's everything. It's candida, it's pneumocystis, it's bacterial. And these patients really have super infections. No question about that. Statistically significant increase in prevalence of secondary infections. And so clearly there's a problem with tocilizumab in terms of secondary infections. So what this group of investigators did was they started off with tocilizumab off the bat, just like we're starting off in this seminar. They started everybody on tocilizumab with steroids straight away. They studied about 130 patients, and you can see here that there was some benefit in these patients, and about 6% versus 34% who did not benefit. And so their conclusion was small study, start both steroids and tocilizumab early. Now, obviously, these are the trials which are going to guide our practice in the ensuing months. This large COVACTA trial, and more important, tocilizumab is one of the arms of the recovery trial, the trial that makes such a huge difference in practice today. Just a word, this is a level, this is a meta-analysis of IL-6 levels. And you can see here that IL-6 levels are clearly on the right side of the mean in patients who have severe COVID. There's no question IL-6 levels are raised. But to me, looking at the literature, I would use it just like any other inflammatory marker. I'm almost done. Last slide.
No, sorry, we couldn't see your last slide.
Okay, so this is the meta-analysis of studies looking at IL-6 levels. And you can see here that they are all elevated in COVID. And here, and to me, I would use IL-6 levels just like any other inflammatory marker. Certainly high levels don't predict response to tocilizumab. The largest study did not use IL-6 levels to recruit. They just looked at oxygenation, and certainly not worth remeasuring because it's bound to go up if your drug has effectively worked. And just finally, to play the devil's advocate, is all this relevant at all? This lovely article in the Lancet, JAMA Internal Medicine suggested that we are really not seeing a cytokine storm in COVID. For instance, in conventional ARDS due to sepsis, other causes, you see much higher levels. And certainly in CRS, which is what we're trying to mimic here, you see 1,000-fold higher levels of IL-6. And if you look at single cytokine interventions for the last 20 to 25 years in sepsis, they haven't really worked. So are we jumping the gun on tocilizumab here? So based upon all this, this is what we do at Apollo Chennai. If somebody is worsening despite anticoagulation, steroids, antivirals, everything else, we give this agent, hopefully before they get on the ventilator. But just yesterday, I had a patient I started this drug on, and this patient was on empiric echinocandin, and on echinocandin, candida grew in the blood. So it really messes up your infection risk. So this is my final slide on tocilizumab. I would call it a two-edged sword. It is an IL-6 receptor antagonist. Retrospective studies show benefit. Don't measure IL-6 at baseline to decide whether you're going to give this drug. Just go by how bad the patient is oxygenating. It clearly increases the risk for secondary infection. It is relatively expensive. And my take is I would reserve it for severely hypoxemic patients not responding to steroids and other measures, and we're eagerly waiting randomized controlled trial data. Thank you very much.
Thanks ever so much. One request, I don't know where the scribbles have appeared from everywhere. So somebody is using something that they shouldn't be using, because we are seeing all kinds of colors, which of course adds color to the presentation, but of course is disturbing. Thanks so much, Ram Gopal, for an excellent presentation. And I have to acknowledge the fact that we at Apollo have now brought out version 21 of our guidelines. And Ram has played a stellar role in looking at all the evidence and presenting this every Friday or Saturday. Now that we've used the machine gun, and we've used the most expensive machine gun, I think we'll come down to Mother Earth and go on to steroids. use something that we started using when we were interns. I want to thank Sudhakar and Ram for the first session, and we move on. And I want to invite Dr. Nandkumar Jairam. Dr. Nandkumar Jairam is a distinguished surgeon. He is the Group Medical Director and CEO of Columbia Asia Hospitals. He served as the head of NABH, head of FICCI Healthcare, and is currently the Vice President of GAPIO. Over to Dr. Nandkumar.
Thank you, Anupam. Let me get along with the introduction of Dr. Girendra Sadera, who is the next speaker. He graduated from the All India Institute of Medical Sciences, New Delhi, and is currently working as consultant and research lead in critical care at Wirral University Teaching Hospitals in the UK, and has been in this position for the last 15 years. He has several international publications and involvement in multicentric national trials. Dr. Sadera.
So Girendra, go ahead and we'll move the slides for you.
Okay, can you hear me now?
We can hear you, and your first slide is on.
Thank you very much. First of all, thanks for inviting me. I just want to make a slight correction to that introduction before we start. I didn't graduate from All India Institute of Medical Sciences. I was a senior resident and a consultant there. So I just thought I'd get that clear. I've been asked to talk about steroids. What I'm going to do is I'm just going to concentrate on dexamethasone. I'll talk a bit about the recovery study, and I'll probably talk about our experience as well. Now, we as you know, were pretty badly hit by COVID. I work in an 18-bedded intensive care unit, and we had an overall case fatality which was similar to national figures, which was around 26%. It was around 1 in 3 of every patient who was mechanically ventilated. Now, when we first started remdesivir, we were very conscious of the fact that all it does is it shortens time to recovery. We didn't really have any agent which reduced mortality, which is why the recovery trial was started. And as you know, the recovery trial has got a number of arms. One of the arms, which I'm going to talk about, is the steroid arm. If you can go to the next slide, please. If you can shift to the next slide. Yeah, great, thanks. So in that arm, you've got 2 groups. One was dexamethasone, 6 milligrams once daily up for 10 days. And the other arm was a usual care one. And the primary outcome was pretty straightforward, just 28 days mortality from randomization. Somebody seems to be using clip art again. I don't know who it is, but
whoever's doing this, please stop this, please.
Yeah. If we can go to the next slide, please. If you can shift to the next slide. Yeah, great. Now, we had in this group, in the steroid group, there were around 2,000 patients which were allocated to dexamethasone and over 4,000 to usual care. As you can see, the majority were male. There were a number of people who had a comorbidity, and over 2/3 of the patients were either invasively or non-invasively ventilated or were on oxygen. If you can go to the next slide, please, that'll be great. Yeah, great. Now, as far as the results were concerned, what you can see straight away is that 1/3 of the patients, the 28-day mortality was reduced in 1/3 of the patients who received dexamethasone who were invasively ventilated. It went down to around about 1/5 in those people who are not on oxygen. There wasn't any benefit, however, in patients who weren't on oxygen. Now, what they also saw in the dexamethasone group was that the patients who benefited were around about 10 years younger, and they had had symptoms for around 7 or 8 days before they came to us. In the usual care group, you can see those who didn't receive dexamethasone, the mortality was significantly higher in patients who were mechanically ventilated. In fact, it was more than 40%. If you can go to the next slide, please. The next, yeah, great. Sorry, yeah. So what was the pathophysiology of all of this? Now, why 7 days, and what was the indication for that? So essentially what they say is that viral shedding in COVID, unlike in SARS, if you can go back to that slide, sorry. bile shedding in COVID, unlike SARS, happens in the first seven to 8 days. And after that, it's inflammation. And that's why dexamethasone seems to work as an anti-inflammatory agent. Go to the next slide, please. Right, so essentially the conclusion of the recovery trial was that dexamethasone 6 milligrams for up to 10 days reduced the 28-day mortality, from randomization. So essentially what you'd have to do is you'd have to treat 8 patients in the mechanically ventilated group to prevent 1 death, and 25 patients in the oxygen group to prevent 1 death. However, surprisingly, there wasn't any benefit, and in fact, they found that there was possible harm in patients who weren't on oxygen. So as a result of this, if we could go to the next slide, please. As a result of this, the Department of Health issued certain guidelines, which we are following. Essentially, we're using dexamethasone, 6 milligrams OD, in any patient who's hospitalized, who requires either invasive or non-invasive oxygen. We're not using it in children as yet. When we've got pregnant patients, we convert that to prednisolone. Now, the dosage schedule, as you can see, we've got tablets, solutions, IV. That's more or less standard. The only thing is that if the patients are discharged within 10 days, we stop the treatment. So that's essentially a sort of what's happening in a nutshell. We, apart from dexamethasone, as I'm sure all of you have, we've tried methylprednisolone. All the patients who are on inotropes receive hydrocortisone as well. We're hoping that this produces the same results we've seen in the recovery trial. And if you can go to the next slide, please. I've just added some references. If anyone's interested, you can use these references. If you can't get them, just let me know and I'll be happy to help. Thank you. Thank you very much.
Thank you so much for sticking to time. And thank you, Dr. Nandkumar, for moderating this session. So we move on to the next session, and we're going to have Dr. Sudhir Parekh. Dr. Sudhir Parekh is the chairman of Parekh Worldwide Media. He's an expert in immunology and allergy, and he is the vice president, he's the secretary general of GAPIO, has been awarded with the Ellis Medal, the Pravasi Bharatiya Samman, Padam Shri, and the Knight from Malta. So over to Dr. Sudhir Parekh. Over to you, Dr. Sudhir Parekh. Sudhir bhai, can you come in? Dr. Sudhir Parekh, please.
Hear me?
Yeah, now please go ahead.
Okay. Dear friends, good morning, good afternoon, good evening. Welcome to GAPIO COVID-19 webinar. It's a very successful webinar for last 2 months, and really the physician all over the world has enjoyed this webinar very much. It's my privilege and pleasure to introduce Dr. Pawan Bhattraju. Dr. Pawan Bhattraju is an assistant professor in the Division of the Pulmonary Critical Care and the Sleep Medicine at the University of Washington. Dr. Pawan is part of the group who was pioneer in publishing US COVID-19 cases in New England Journal of Medicine early enough. Dr. Pawan is also co-principal investigator in study where they collected biological specimen from the very ill COVID-19 patients to understand the molecular mechanism of the disease. Let's welcome and hear Dr. Pawan Bhattraju. Welcome, Dr. Raju.
Thank you. I'd like to thank the organizers for the invitation to present. This is particularly exciting because growing up, my father is a surgeon, and so we would attend OPI events often. And so it's exciting to be able to present to this group. I'm going to briefly be talking about the historical precedent of using convalescent plasma and the limited data currently available for this therapy. So on the left, you see a schematic of whole blood, and after centrifugation, plasma is the milky fluid that's found in the blood. This contains immunoglobulins as well as other factors. So the mechanism of action is to think that after someone is recovered from SARS-CoV-2 infection, to collect their plasma and then administer it to patients with COVID-19 infection to prevent or treat the current infection using the neutralizing viral antibodies. Currently, this is FDA approved in the US through an investigational and an emergency IND. Convalescent plasma for the treatment of infectious diseases has been used since the early 20th century and was associated with reduced mortality during the 1918 influenza pandemic, the 2003 SARS-CoV-1, as well as the 2009 influenza H1N1 pandemics. However, most of the published studies of these diseases were case series and retrospective comparisons of treated versus non-treated individuals. Despite this, because of the encouraging results, there's been precedence to use this in COVID-19. There's been a handful of different case series that have been published in COVID-19, but I really want to focus on the largest randomized control trial currently available. So this study was published in the Journal of the American Medical Association in June 2020. The investigators were from China, and the expected sample size for this study was to be greater than 200 patients. However, the investigators said that because of the pandemic was under control in China, they were unable to enroll patients, and so they stopped at 103 patients. Half of the patients were randomized to the convalescent plasma group, and half of the patients were in the control arm. As you can see from the table 1 demographics, the average age was 70-year-old or older. And as can be seen in most case series of COVID-19, coexisting diseases, especially cardiovascular diseases, were common. One of the things to note about this, in the previous pandemics when convalescent plasma was used, such as SARS-CoV-1 or influenza, it was mostly used in a younger patient population and earlier during hospitalization. In this randomized control trial, each patient had an average symptom duration of 30 days or longer prior to getting enrolled in the study. So it was mostly used later in the disease. It's also important to note that many of these patients received other therapies, everything from antivirals, antibacterials, steroids, as well as antifungals. So it's challenging to know exactly if the results are due to convalescent plasma or from these other therapies. Their primary outcome, so on the left here is the cumulative improvement rate, is the percentage of patients who experienced a 2-point improvement or were discharged alive from the hospital. And so you can, as you can see from these two Kaplan-Meier curves, there is no statistically difference between the placebo group versus the convalescent plasma group. But I think one thing that to notice is that in subgroup analyses, these are smaller patient populations because the study in general was underpowered, but it looks like there may be a trend toward improvement in the patients with less severe disease. So on the panel on the left here, you can see the convalescent plasma group had a statistically improved outcome, but then on the panel C, these are patients who are critically ill in the intensive care unit, there's no difference. Another takeaway from this study is that they looked at viral nucleic acid negative rate. And so here they did PCR to see COVID-19 infection at 24 hours, 48 hours, as well as 72 hours. And you can see the convalescent plasma group at 24 hours, almost 47 or 44% of the patients had negative PCR compared to the control group, where it's 15%. And these differences persisted throughout the first 72 hours, potentially suggesting that convalescent plasma is allowing for clearance of the viral infection. The two main concerns that we have with convalescent plasma are issues of transfusion-related lung injury, as well as transfusion-related circulatory overload. In this study by colleagues in Lee et al. And colleagues in JAMA, they found that there is, they didn't describe either of these two side effects. And from our local experience, we've given this therapy to a handful of patients, and we found no rates of these side effects. So in conclusion, Convalescent plasma is likely to be safe, but studies are limited. The plasma may improve outcomes in select patients, but it's really a challenge of understanding who the right patients are and what the time period to give. And early use of convalescent plasma may lead to larger benefits than later use. And then I just want to end by saying there's over 26 randomized control trials currently underway in, if you look at clinicaltrials.gov. And so I think there's going to be a lot more that's coming out about the use of this therapy. Thank you.
Anupam, you're muted. You're muted.
Okay. Hey, thanks, Pawan, and thanks, Sudhir Bhai, and a very nice presentation, and clearly a lot of information that we need, lots of unanswered questions about when to use precisely, and hopefully the RCTs will shed light, just like that paper on 20,000 plasma therapies shed light on the safety. We'll move on and to the next session, and it's a privilege to invite Dr. Bala Reddy. Dr. Bala Reddy is a member of the Executive Committee of CAPIO and has been the Secretary and President of the Andhra Pradesh Private Hospitals and Nursing Home Association. He's a distinguished physician. Over to Dr. Bala Reddy. Dr. Bala Reddy, please come in. Dr. Bala Reddy, can you please come in? Yeah, Dr. Bala Reddy, please.
Yeah.
Yeah, please.
Thank you, Dr. Sibyl. Let me introduce Dr. Irene, who is a consultant at hospitals. He's a pulmonologist care specialist. He's a board certified in medicine and critical care medicine. Dr. Sai is a medical director of Apollo E-Access Daily ICU services. Can I
Thanks. Thanks so much. Over to you, Sai.
Hi, this is Sai Harnath.
Bala, can you please mute yourself? There's a disturbance at your end.
Are my slides visible?
Yeah, please go ahead, Sai.
Okay, hi. Hi, thanks to the Bala Reddy. Thanks, Anupam. Again, welcome to all the 900 plus people from around the world. Some of you in Australia staying up for us, and some of you spending Sunday morning with us. And of course, all of us in India, thank you very much for joining. I think we have, looking for the treatment and looking for solutions to all our patients, and we are fairly desperate looking for new things, and favipiravir is the new kid on the block. And one of the questions that everybody is asking is it worth the effort and the money? You'll understand why as I go through this brief session. Now, one of the issues that we need to realize is that an antiviral is definitely, it's not a new antiviral. It was used in Japan for several years now for influenza. In addition, it was used in Africa for the Ebola crisis. And there are many trials going on. That's a picture from clinicaltrials.gov showing you all the studies going on around the world right now using favipiravir in various combinations. So there is a fair amount of research that is going on. Unfortunately, many of these trials have not yet started. Only some of them have started. Only 2 or 3 have actually finished. And of them, the Bangladesh RCT Dhaka trial, as they call it, finished yesterday. And I didn't make my slides for a while. And one of the things that I realized was that a lot of the data is coming out in the media and in preprint, and it's not yet come in publications yet. But of this group, they had 25 treatment group and 25 placebo group. Looks like they stuck to the protocol that was released on clinical trials. They also noticed there was a viral clearance by day 4 in half the patients in the treatment arm, and almost 96% by day 10. About 44% had more lung function than placebo. Actually lung clearance than placebo, and about lung function improved about 3 times more than placebo. And now this is a very tiny trial if you think about it. Just 25 people actually got the drug. So it's really unclear if this effect will be seen in a larger scale. Now, anecdotally, I've been asking friends around on the various groups, are you using it? And what I've heard is several people are using it, but if you look at the exclusion criteria for this trial, pretty much anybody who's sick is not going to get it. Now, there are
some RCTs going on in the US and the UK. There are several open label trials in France, Turkey, and Iran, and these are completing in 2020 and 2021. Now, the way that favipiravir works is it tries to incorporate itself. So as the virus enters in, it gets uncoated, and then it gets into the cellular mechanism, and the favipiravir blocks the RNA-dependent RNA polymerase enzyme and incorporates itself and kind of puts a stop to the replication. Now, the virus is actually pretty smart, but this particular drug incorporates itself in a particular place where it cannot compete. And what you would see is that ultimately the viral replication is affected, and you actually get a decrease in the viral release. The next component is a trial that has come out in critical care last month in end of June. And they actually showed an interesting thing where they started the favipiravir around day 4 or so. The day 1, and then they started measuring all these things. About day 4 after the favipiravir administration, they noticed inflammatory markers coming down. IL-6 came down, plasma sepsis came down, the PS improved. Now, incidentally, I mean, they didn't stress on in the article, but if you look at the article, the steroids were started right about this time. So people got steroids right around the time that these numbers started coming down. So I have a feeling this is more a steroid effect rather than a direct antiviral effect. Another trial, which was again from Japan, showed that a combination of this drug called nafmostat, this works on a particular enzyme, serine protease enzyme, and it's used in actually acute pancreatitis. They combined this drug with favipiravir and again showed in a case series that there were many discharges. Again, this is just anecdotal information, and these are very observational trials. Some of them are retrospective, so the data isn't clear, but they showed that some patients got home early. Again, the exclusion criteria were if you were sick, you didn't get in. Now, there are some case reports from Thailand and Turkey. There is one from Thailand where there are renal transplant patients who got a combination of tocilizumab where they actually had an improvement in the pneumonia. Likewise, another case report from another country where the patient did not survive. So you're getting all these stream of information, and what is the conclusion? What do you actually do? India, actually, they have completed some studies. The data from the Indian study is not yet available. I looked till yesterday, in fact, today I could not find the actual data released from the current trial. It was an observational open label trial. There was no real randomization as such. It was done on very mild patients. If you are even on non-invasive ventilation or in the ICU, you are not eligible. Pregnant women cannot be eligible. There are about 3 open label trials going on at this time, and the data should be coming out soon, but the numbers are not gigantic. They are going on in several centers though. Now, what is the complete conclusion of this data? Now, Russia, Japan have shown some benefits. India, there's anecdotal data saying it may be beneficial. However, they used all these trials as very obsolete comparators. Many of them use the HIV antivirals, and they're not using them anymore. It is unknown if the natural history of viral clearance is accelerated. Maybe that's the only thing that's going on. And the RT-PCR test coming negative, I'm not sure what the implication of that is, whether you can conclude quarantine sooner or not, because really you don't know if you're still having viral shedding or not. And lastly, will it impact antibody formation? If you don't have the virus, will your body make antibodies? What is the implication of that? So there are some side effects of this drug. These include a uric acid elevation. So you should get a baseline uric acid and not use it in somebody who has gout. Some people get diarrhea. As with other drugs, watch the QTC. There have been anecdotal reports of bradycardia from colleagues who have been using this drug. This drug has been shown to be teratogenic and embryo. It has issues on the embryo. So if they're pregnant, you should not use it. The conclusion, it is expensive. It is not cheap. The benefit is unclear, perhaps similar to how various influenza treatments are there. I think we should wait for the data to come out before we use it more widespread for sicker patients. If you want to use it, please review the dose. It's a lot of pills to swallow. And that's about it. Thank you very much. So the conclusion is favipiravir, more to come. Keep an eye out on whether this is beneficial or not. As of now, most people I know are not using it, is what I've heard, especially in sicker patients. Thank you.
Thanks so much, Dr. Bala Reddy. Thanks so much, Sai. We move on to the next session, and it's a privilege to introduce Anupama Gotimukula to moderate this session. Anupama is a pediatric anesthesiologist and in Texas at San Antonio, and she's currently the Vice President of API and the President-elect of API for 21-22. So over to you, Anupama.
Thank you, Anupam, for the kind introduction. So we took over yesterday evening. So I'm the current President-elect for API now. from today. And so I'm very happy to introduce a very good speaker today, very young and dynamic, Dr. Pooja Shah. She is an infectious disease specialist practicing in New Jersey, USA. And Dr. Pooja completed her internal medicine residency at Seton Hall University in Newark and obtained her fellowship from Eastern Carolina University in North Carolina. She was the principal investigator for the expanded access program with Gilead involving the drug remdesivir at Hackensack University Hospital at JFK University Hospital, New Jersey. Pooja, welcome. We would like to hear from you more about this drug, remdesivir, during this phase of COVID now, and it's your turn.
Thank you for having me. Okay. I'd like to thank everyone for having me today. I'm going to talk about remdesivir. So just some general introduction. So we know this is an inhibitor of the viral RNA dependent. It's an RNA polymerase. Remdesivir showed in vitro that it can inhibit the replication of the SARS-CoV-2. It's still an investigational drug manufactured by Gilead, and there's still ongoing research about the drug. Now, remdesivir is actually initially was used to be for Ebola when Ebola first came out. It had limited effect, but it showed that it was safe to use in humans. That's what came out of that. So what's the criteria to initiate remdesivir? Obviously, you have to have a positive SARS-CoV infection. It's used for hospitalized patients with severe COVID-19 disease, which is defined as your saturation less than 94% on room air, requiring supplement oxygen, either nasal cannula or high flow, or being on a mechanical ventilation, or requiring ECMO. You have to have a GFR greater than 30 mils per minute, and your liver enzymes, AST, ALT, has to be within 5 times upper normal limit before starting. When to discontinue remdesivir? When your ALT is greater than or equal to 5 times upper normal. However, if the enzymes start to come down, you can always restart the drug, which is a good thing. Or when you see ALT elevation accompanied by other liver inflammation like elevated bilirubin, alkaline phosphatase, or the INR. Some people have been reported to have a hypersensitive reaction, and if their GFR drops below 30. Some side effects that have been noted is the liver enzyme elevation, some GI disturbances, infusion reaction like nausea, sweating, and low blood pressure. And there's still ongoing research about other side effects that have to be studied. So I'm just gonna go more in my experience with the drug. So like you said, I am the principal investigator for the expanded access program with Gilead. So basically this program was set for our intubated patients with the strict criteria, and that means they would have to be off pressors, their GFR was greater than 30, AST, ALT within 5% of the normal limit, and they had to be intubated. But with that, when patients are intubated, their mortality was already starting up at a high mortality from the beginning. So we enrolled about 62 patients. In our hospital, it was mostly males that we had, and majority of our patients were on steroids from the beginning. As for other treatments for COVID, while in the remdesivir, they could not receive any other treatments. It was either prior to starting or after, and they did complete a 10-day course during this process. Our outcome mostly was we had about 23% of our patients come off the ventilator, which was good given that the mortality is already high from the beginning once they're intubated. So we did see some good outcomes. The one thing we noticed with our intubated patients actually was that a lot of them went into renal failure. And so once I realized that this was happening, we actually started giving pre and post boluses with fluids, and that helped with the renal function. And also when people's renal functions were between 30 to 40 of their GFR, we were very cautious about starting and make sure we bolus them just to prevent, because once they go into renal failure, we noticed our patients were not doing very well. So we try to do everything to help prevent things that we could for these patients. We also noticed a lot of our elderly patients didn't do well. It could be because of comorbidities, but there's so much still that needs to be researched into this. But that was just our general experience that we saw with that. With that, then in the US, they ended up having remdesivir become emergency use of remdesivir by our FDA. So with that experience, it allowed us to give remdesivir to our non-intubated patients. And the criteria at that time was that it had to be 94% saturation, GFR again above 30, AST/ALT 5 times within normal, and they had to be within 10 days of diagnosis of the COVID infection. We actually have a small sample size of just 27 patients, mostly males. During the emergency use, we use mostly 5-day duration instead of 10 days. But something we learned is that sometimes you can give if you need to give 10 days, we gave it for our intubated patients or the ones that were more sick. And we had about 70% complete the course, which is good. But the one thing we noticed more, that people are having more liver failure when we use the emergency use. So that's why you have to watch your patients carefully in the labs. The main thing out of all this, we noticed with remdesivir, early is the better. If you can use any treatments, early is better mostly. We actually started giving plasma first, and then we would give our patients remdesivir. You know, remdesivir is one of the antivirals that brings down.
Pooja, your slides are not moving. Sorry to interrupt.
Oh, that's okay.
Okay.
That we noticed that it brings it down, to help bring the patients down. So we would try to space out all our treatments. So if you give plasma, tocilizumab, or remdesivir, try to space them out by 12 hours at least if you can, just so we don't know, because you don't know if there's co-interactions with any of these treatments. So we try to be more cautious and monitor your labs closely. And the good thing about remdesivir, if the labs are abnormal, you can watch them, and then you can always restart the drug as well. And it does help with the length of stay. It does bring down the recovery in adults. It was mentioned in the New England Journal of Medicine that the take-home message for this is it shortens the time to recovery in adults hospitalized with COVID-19. And the last thing I want to say is timing is very important. The earlier, the better for all these COVID-19 patients. And we did use steroids in all our patients as well. Let's see. Thank you.
Thank you so much, Pooja.
Give higher doses or perhaps even therapeutic anticoagulation if I can't rule out a pre-existing thrombotic event. Thirdly, I would give remdesivir, provided the patient is not yet ventilated, because the data clearly shows that it doesn't help once you end up on the ventilator. And there is perhaps modest benefit in reducing time in the ICU, etc., without a mortality benefit if you are not yet on the ventilator. So that is that's my order of prescription in the average COVID patient. In somebody who's not responding to 1, 2, and 3, I would give tocilizumab. And I've become increasingly more reluctant to give this drug because of the side effects of the drug in terms of secondary infection. All it seems to do is it maybe helps acutely, but the patients hang on in the ICU for days, sometimes weeks, and end up with secondary sepsis. So in order of importance, steroids, secondly, anticoagulation, third, antivirals, and finally, tocilizumab.
So you don't like the plasma. Is there a reduction in the second dose, or what is the maximum dose you've given for tocilizumab?
I give 800, 400 stat, and 12 hours later, I would give a second dose of 400. To your question on plasma, there is absolutely no data that plasma works. The speaker on plasma would, I'm sure, take that up. The single randomized control trial showed no benefit. To benefit from plasma, you need to give it in the first 7 days before antibodies form. And a big European study showed that the majority of patients who present with severe COVID already have antibodies. So you're just wasting your time giving plasma. So I'm waiting for that.
So the last question to you, it's about IL-6. People at all over centers, unless the IL-6 is high 8 to 10 times, they would not give tocilizumab. Is it really necessary to do an IL-6? Number one, be short. And the other, or you should not use it. If it is not available, you should not run for IL-6. That's number two. And the third, at an economic cost, is the tocilizumab really useful? You partially answered, but be brief, because then we go to the next segment.
Yeah, I would treat IL-6 just like a rich man's CRP, LDH, etc. D-dimer is really the one biomarker we should be doing. If it is high, I would not base a decision on giving tocilizumab. I would look at the oxidation. That is what the largest single study which I presented showed. And finally, I believe tocilizumab is costly, but I'm reluctant to use it mainly because of the secondary infection risk. That is my biggest concern.
Thank you. Over to Dr. Ram Subramaniam for the next section.
Thank you, Rajesh. For people who can't see me, I'm actually logged in through Aruna Mohan, my wife. I apologize. Good evening, everybody. We have had a good session, and my questions are to Dr. Sadera. There is a lot of evidence in India. I know the recovery trial is using dexamethasone, but a lot of people in India seem to prefer Solumedrol. Have you used Solumedrol? What are your views on using Solumedrol instead of dexamethasone?
So we started with methylprednisolone and hydrocortisone. And when the recovery trial came in, and when we were instructed by the Department of Health, we switched over to dexamethasone. So actually, these are the only 3 drugs we've used as far as steroids are concerned. Methylprednisolone, when we started using it, we were essentially using it when nothing else was working. So we had patients who had been proned and unproned maybe 2 or 3 times. They were basically at death's door, and then we started 1 milligram per kg BD. For a few days. It worked in a few patients. The thing is, the recovery trial, our patients, when they come in, they essentially, dexamethasone has already been started on them because they come to us from the respiratory ward. So essentially, these are the 3 drugs we've got experience with, 3 steroids we've got experience with. And as such, I think after we started dexamethasone, we have seen better results, definitely. Having said that, in the UK, what we're seeing now is that we're on a downward trend, unlike in India. We hardly have, in fact, we don't have any COVID positive patients on the unit at present. And the last patient in the hospital was around 3 days ago. So I think you're probably going to reap the benefits more than us.
Right. What about, there seems to be a potential interaction between remdesivir and dexamethasone. Do you think it makes a difference in real life?
It's difficult to say. Towards the end, we were using remdesivir and dexamethasone both. The problem is what we do, a lot of it depends upon the arms of the trials we're actually in. So we had the recovery trial, and for intensive care patients, we had the REMAP-CAP trial. So depending upon which arm the patient was in, we did towards the end start using remdesivir and dexamethasone. By that time, we were starting to get really good results. Now, who knows whether it was due to dexamethasone or whether it was due to remdesivir? It's difficult to say.
What about, is there a different dose used in pregnancy? Pregnant women, have you used steroids?
So we as such, we didn't have a pregnant woman on our unit, but according to the recovery trial, what they say is you've got to switch over to prednisolone instead of using dexamethasone. I can get you the dosage schedule. I don't have it with me now, but I'm sure I can get it for you.
Lastly, briefly, do you think there is a role for steroids in an outpatient scenario? That is, before he gets admitted, do you think steroids can prevent hospitalization or ensure that hospitalization is minimized?
Okay. Again, we have very strict rules on what we can do and what we can't do. So dexamethasone for us in COVID, we are only allowed to prescribe it when the patient's hospitalized. I'm not sure. I think, I suppose, I personally don't see any harm. But at the end of the day, we have to go according to what the guidelines are. So that's just how it is.
Thank you very much. Over to you, Rajesh.
Thank you.
Okay, so before Rajesh comes in, Ram and Rajesh and Dr. Sadera and Ram Gopal Krishnan, any one of you can answer this. This is really a very important question because there is a group in the US that's advocating use of steroids in outpatients, and I know there is no trial, and I don't even know if such a trial is going to be possible now. But what do you say conceptually? And this group believes, and they've been posting on this group that, if you actually did that and not worry too much about viral replication, you would actually prevent hospitalization, which is really the goal. So anyone wants to comment on that? And I know there is no data, and I'm asking this question conceptually.
Okay, I can take that if you want. See, the issue with COVID is we don't have a good antiviral. We definitely don't have a good antiviral for severe disease, and we don't have a good antiviral like, say, oseltamivir for influenza for mild to moderate disease. So if you're not giving an antiviral to a patient who has active viral replication and you give steroids, the concern is things will get worse. So I am not in favor of giving steroids without a concomitant antiviral. I would rather wait for clinical data from someone showing that that approach works.
The other thing is, Anupam, we have so far bed availability is not an issue all across India. So I think if a person, there is an indication of giving steroid, better to admit and give under supervision. Like Ram said, I think we should not indulge, because every patient would be receiving, and we may see complications which are not being seen now.
Okay, so I mean, that's very helpful. So what you guys are saying is we don't have an antiviral, so you really want to hedge with remdesivir is what you're saying, and do that in a hospitalized environment till we actually get some data. And I just hope some data comes on the outpatient setting. Over to you, Rajesh.
You know, these are the questions for plasma, you know, because plasma did not get that attention. The Ram Gopalakrishnan said that he doesn't like it. So let me ask you a question. What are the indication of repeat plasma? Let's go a little ahead. And what is the gap between the first and the second dose? Pawan.
Thank you for that question. In our experience, we rarely ever give repeat plasma. And so often what we do is the first dose of plasma, if we can give, is earlier during hospital admission. We can check antibody titers in the recipients, patients receiving the plasma, but we don't often do that because it doesn't influence our management. After we give a dose of plasma, that's usually it. We are not giving a second dose.
So what is the dose you are giving? How many?
So it's usually 200 to 400 ml of volume. You could get a smaller volume from that, and then that is just an IV transfusion. There's minimal side effects we see, but as the speakers have said before, this is usually a third or fourth line therapy we offer, and it's often challenging because consent is required. It's an investigational drug therapy, and so the other therapies that have been talked about are earlier given and more prioritized.
So which day would you consider to give plasma in these patients?
Because of the limited resource, we are prioritizing ICU patients. And so we're giving it earlier in the ICU, ideally within the first 7 days of ICU admission. One of the things that's interesting about the clinical trial that I talked about, the average time of symptoms was 30 days or longer. So it is surprising because most people think you should give it much earlier during disease. And so even at 30 days or longer, there was active viral replication and potential benefits from plasma. But again, that was a small study.
So last question, what are the contraindications and what percentage of patients in your experience you've seen TRALI?
Yeah, this was on the chat asking before. It's, you know, with TRALI, we really worry about HLA antibodies and some immune reaction. Pregnant women in most studies are not able to donate convalescent plasma. In our experience, we've given convalescent plasma to 30 different patients, and we haven't seen any episodes of TRALI. There's been 2 episodes of circulatory overload or volume overload, and those have been treated with diuretics and the patients have done fine. And so we haven't seen too many side effects, but it's hard to know if we've really seen efficacy.
You know, just a little small question. How early one can donate plasma? Because all countries have different criteria for donating plasma. Like in India, after the person is symptom-free, 28 days after most of the studies and people are donating. And the other thing is RT-PCR at the end of the treatment necessary? And from there you consider, or 28 days from symptom-free? That's a very important.
Yeah, it's as you've said, it's variable across continents and across centers who collect convalescent plasma. Our experience is we're waiting until PCR testing is negative, symptoms are negative, and then we're acquiring convalescent plasma. We're checking antibody titers in patients who are donating convalescent plasma. So there are many people who recover from COVID-19 infection but may not have high enough antibody titers to qualify to donate convalescent plasma. And then there's other steps that are required, but then they're asked to donate.
Thank you, Pawan. So over to Ram for the next.
If you go on to Ram, I have a doubt that I want to clear. And, you know, if you look at the plasma papers, and I've been looking at most plasma papers, and especially the Dutch study has actually changed the whole outlook. If the ones who are really getting sick have strong antibody titers as patients, and we give in plasma when they already have antibodies, what are we achieving? And in fact, we want to start measuring antibodies before we consider anyone for inclusion in the trial for plasma, and we are part of a multicentric trial. My question is conceptually again, because unless the RTCs, RCTs get published, we won't have this. But wouldn't plasma really help in the first few days? Because if you're going to develop antibodies in the ones who get sick, what is the point? And again, so much confusion. If you look at some of the initial trials, the plasma has been collected from individuals without measuring titers. It's been done very randomly by just looking an arbitrary number of days after recovery. So honestly, it's a little bit of a fuzzy situation with plasma. So Pawan, why not give it very early?
Yeah, and I completely agree with what you're saying. I think, as you've said, there's a lack of data in this field, and really there's not a lot of published data explaining when the convalescent plasma was collected in what patients. I think early sounds reasonable. I think clinically, and doing that often is challenging because patients present, as we've shown in our studies and others have shown, usually a week or longer after symptoms. And so unless you're moving this to the outpatient setting, there's going to be times where you're administering convalescent plasma a week or 2 weeks after symptoms have started.
Thanks, Pawan. Over to Ram for the next slot.
Yep, thank you. And the next couple of questions are coming your way, Sai. You mentioned very clearly that there is very little evidence for using favipiravir, but if you decide to use, what is the timing? When would you use? Would you use it only in the outpatient setup, or after is there any role after the patient is admitted?
So as of now, again, there is zero data, but there's a lot of anecdotal data accumulating, especially in India, because there's very little restriction in who uses it. I have known patients who have been hospitalized who have been getting it, but honestly, we do not have information on what the outcome is. The guesswork would be that if it worked for influenza, we would expect to use it similar to influenza, but coronavirus is not influenza, so we have to wait and watch. I know that there are several patients who have been getting it in the outpatient setting, and it is a lot of pills to take, and many have actually not tolerated what I've heard. You have to watch the uric acid level also. There has been, out of desperation, people are doing it, and I'm hoping that people who are doing it actually keep track of the information and maybe even publish it. There was somebody in the chat who said he has treated several patients with it. It would be worthwhile really if you can actually collect your information and go ahead and publish that information, because it will help others.
And similarly, the dose also is very varied from 1200 to 1600, 1800, 3200. What is the dose you would recommend?
So I would go with the Dhaka trial, which just concluded. This is different from what the Indian regulatory dose is. The Dhaka trial used, I think, 3200 and then 1600. So it was a pretty high dose that they were using. In fact, they did like 200 milligram tablets, like 1600 on day 1 twice, and then day 2 to 10, they used 600 twice a day. The standard treatment was oxygen, intravenous rehydration, electrolyte correction, analgesics, antibiotics, and anti-emetic drugs. So, and there was only 25 patients who got the drug. So honestly, I think I would go with this trial because this is the closest I have to say blinded, not really blinded, but a placebo comparator. All the other comparators or drugs we're actually not using now. So I think to me, this was the most meaningful so far. Now, one question actually I have back at you is, there's several questions coming up because you guys are infectious disease. Many are asking, should we put these patients on antibiotics? Do we need to use antibiotics? That's a clinical question. What are your thoughts, all the ID specialists here?
I'll say on behalf of Ram Gopalakrishnan also that I don't think there is any role for antibiotics. We don't use antibiotics if the patient is confirmed to have COVID. And if there is no reason to suspect anything else, we don't. We, of course, do a procalcitonin and then tend to repeat it after a few days. The only time when we consider is, as Ram Gopalakrishnan has said, if the person has received the tocilizumab or if the patient goes on a ventilator and continues to deteriorate, we rule out venous thrombus, thromboembolism, pulmonary embolism. In that situation, we consider antibiotics. Is there anything you want to add, Gopal?
No, I agree with that, Ram.
Carry on.
There's one question which is not related to what you spoke about, Sai, but this has come up that if a person dies in India, a person dies 2 to 3 weeks after having been admitted with COVID, is the death still considered as related to COVID? Even though he recovers after COVID, would you still, what is the current status?
I don't know the answer to that, but I think I would hazard a guess that on the death certificate, you would probably put that in because we are seeing some late presentations, perhaps under-recognized inflammation, under-recognized hypercoagulable state, and unlikely under-recognized infection, more likely, I think, an under-recognized hypercoagulable state. I think that would be it. If you look at the autopsy studies that the NEJM published, there is a fair amount of microclotting happening in a fairly diffuse manner. So whether that is what is causing this is unclear. Now, one of the other parts in terms of mortality statistics, it would, I think, behoove all of us to start documenting what the cause of death is, because without knowing the exact cause, we will not know. There is also the concept of the verbal autopsy that has been used in several countries where they make phone calls, even ask the family, what did your family die of? And that has been validated as a reasonable way of estimating the cause of death.
Thank you. Over to you, Rajesh.
Thank you. So my questions are for Dr. Pooja Shah related to remdesivir. This is a very odd question. Person has symptom of COVID, RT-PCR negative, but CT is very classic. Can you give remdesivir in this patient who is hypoxemic?
So the thing over here in the US, we need to have a positive COVID swab in order to give remdesivir. Because what we're under the expanded access, we had to give it because of that was part of the requirement set by the Gilead company, and it's also set by the FDA. So unfortunately, without the positive test, we can't give remdesivir because we're being monitored by the FDA here in the US.
So if there is a person who is having a cytokine storm, and would you like to give remdesivir and tocilizumab together, or is there any interaction among them?
So what we've been doing here in New Jersey is we try to space out all our treatments because we don't know the co-interactions. So we would give tocilizumab first and then wait before we start remdesivir. Because we have actually seen good outcomes with our patients who got tocilizumab when they're in cytokine storms. And so we feel that was working more. And remdesivir might take some time to work on patients. So that's why we would first give the tocilizumab and then the remdesivir.
How many days after the tocilizumab?
We space it between 12 to 24 hours.
So almost within a day, you start remdesivir.
Yeah.
And there was this concern about the remdesivir and Dexa. Can you combine these? Can you talk a little more about this?
It's over here, we just started using more dexamethasone. We've always been using Solumedrol in our patients here. It is all new right now, so it's hard to know what the real interaction is because the data is all outcoming. So I really can't say personal experience because we're just starting to use more dexamethasone here. And so I can't say what it is, but I think we need to do more data needs to come out with the interactions to know. And anything with COVID, it's so hard to know, is it the drugs, is it the therapies, or is it the COVID disease itself? And that's what we've been learning through this whole process with this disease. A lot of side effects we see, is it because of COVID or is it because of the drugs we use? And it's sometimes hard to know which one is causing what in some of these patients.
In addition to the liver toxicity, are there any side effects which you need to look for when you are giving remdesivir?
I've noticed kidney issues, a lot of kidney issues. So that's why I always recommend to give, sometimes you can give, especially the very sick patients, you can give a little bit of a pre-bolus of 250 cc of fluid before and after the drug to help flush out the drug to protect the kidneys as much as we can. And I saw it more in our intubated patients, kidney failure, and our non-intubated patients, we saw more liver failure.
Okay, thank you very much. So over to Ram for the next section.
And before Ram starts the next session, I just wanted to mention to everyone that we are really blessed that His Holiness, the Dalai Lama, will be addressing us for the next session. And it's on the 23rd. And it's because the Dalai Lama, gets up at 3 in the morning. This has to be a morning session. It's going to be 9 a.m. IST on the 23rd. But everyone needs to pre-register. And so anyone interested can just send us a mail at Gapio Database, GAPIO, all small case, database, DATABASE @gmail.com. So Gapio Database @gmail.com if you're interested. Over to Ram.
Yeah, the last section is for Dr. Agam Vora. There are so many available therapies now, including steroids and antivirals and heparin and stuff. So where would you place Sepsivac in this group? Is it along with it? Is it before? Is it after?
Thank you very much for that question. And, to tell you truth, we do not know answers for most of these questions. We in Mumbai are on fire. The cases are, all our hospitals are full of COVID patients. In fact, in my ICU, currently there are 6 patients admitted, all critical. And unluckily, these drugs are not easily available. Remdesivir, you would have read in papers, probably, at double the triple the price, it is not available. Tocilizumab is not available. In that situation, it's do or die kind of situation, and you're trying out all possible immunomodulators that you have experienced. So in that situation, I've started using, Sepsivac, though it is a very initial experience. Only a handful of cases are put on this. So wherever I'm not able to put them on any immunomodulator, as I understand, or as I look at this disease, probably initial phase is viremia phase, and then comes the, cytokine storm. So whenever probably there is more of inflammatory changes going on, at that stage, I would like to introduce some immunomodulator. If I get my hands on this tocilizumab, yes, my first choice would be tocilizumab, because probably there is better understanding about tocilizumab than Sepsivac. But then if I look at the pathophysiology or the level at which Sepsivac works or the proposed mechanisms, probably I am tempted to use this particular molecule in that situation. So where I have used it so far, whenever those patients, I have always given them antivirals, whenever possible. So either these patients are on favipiravir or these patients are on remdesivir. And if they go into the cytokine storm, probably at that stage, I would like to introduce Sepsivac. I have used it in the dose which is what is recommended, and that is 0.1 ml at 3 sites. So I would give it on 2, probably 4 amps and 1 deltoid daily for 3 days. So that is 0.3 ml daily for 3 days. That is a dose that I've used. I will tell you that my personal, I have a bias for all immunomodulators, and my personal bias tells me that yes, it works. I have not done any kind of study, I have not done any kind of comparative analysis, but I think it is working. The only side effect that I see is a big induration patients get, and then there is probably, in some patients, there is ulceration. And in fact, I can show you, I also got a small ulcer on my, I took it myself, and there is a small ulcer formation. So probably these are the only side effects. Otherwise, it is fairly safe.
What is the cost?
Cost is not much. I think it is costing some 2,500. I think 7,000 rupees for three doses put together. For 3 days, I think it will be somewhere around 19,000 rupees max.
And lastly, I'm a little confused. Would you recommend it as part of treatment or as part of prevention?
No, now the whole idea started as a treatment, part of treatment, but then since DCGI gave permission for, the trial was designed for primary prophylaxis as well. And, with my personal experience with this particular molecule for the last 15 years, I thought of taking it. So then a lot of chest physicians across the country, if I can name probably, 35, 40 chest physicians who I know of, have taken it themselves. So we are in the early phase to recommend it as primary prophylaxis, but I'm convinced about secondary prophylaxis and cytokine storm utility for sure.
Thank you very much. Over to you, Anupam.
Thanks ever so much. This was really fascinating. I think the number of questions we covered, of course, we can carry on for another 1 hour. Getting into all the minor issues, but I think the major issues have been covered. And of course, one thing that is loud and clear for everyone's benefit is that we should look at evidence. We should not go with anecdotal, my personal experience here, what one might have heard, because at the end of the day, we have seen so much change in the treatment of COVID-19 over the last few months, and I don't know how much more will change. So I guess we will continue to have more and more of these sessions. We will do another one on therapy next month. We're also going to do one on diagnosis, because I think there's a lot to learn in terms of serology and antigen testing and what have you. I want to thank everyone, and we are really delighted that this time we had 2 very young clinicians, and Pavan, second generation, trained, born in the United States. And I just wanted to highlight that we are encouraging young people to become a part of the faculty here. And of course, everyone is peer reviewed before they're invited to speak. We look at their experience, we look at the research, and we look at whether they've got hands-on experience or not. Really happy to have Pooja and Pavan, of course, very senior, very distinguished clinicians on board as well. Thanks ever so much on behalf of the Global Indian Physician Collaborative. We had 900 plus delegates from across the world. We look forward to welcoming you on the 23rd. for a very special session with His Holiness the Dalai Lama. And like I mentioned, if you want to be a part of that session, please send us a mail at gapiodatabases@gmail.com. Thank you very much, and have a wonderful day, and in Europe and the United States and Canada, and for all of us in Asia and Australia, of course. Very good day.